Now, moving on to our last section, we will be briefly discussing the two very important entities, that is Monteggia and Galeazzi fractures. We'll be discussing the Monteggia fracture dislocation of the proximal third of the ulna, its clinical features, how to diagnose an X-ray, and what is its treatment. We'll also be discussing the distal radius 1/3 fractures along with the radial dislocation, that is the Galeazzi fracture as well. So what is Monteggia fracture? A fracture of the shaft of ulna associated with anterior dislocation of the proximal radial joint. A radiocapitular joint is inevitably dislocated or subluxed as well. The important point is the most commonly it's anterior dislocation, which is also called as subtypes, is divided into 4 subtypes. Type 1 is anterior dislocation. If you see over here, this fracture of the proximal third of the ulna with anterior dislocation. In type 2, this head instead of dislocating anteriorly, it dislocates posteriorly. In type 3, instead of dislocating posteriorly or anteriorly, it goes laterally, which is very much visible in the AP view. Or in the type 4 fracture, instead along with the dislocation, there is a proximal radial fracture as well. That is important. So it is not always, most common it's anterior, but it can be posterior, lateral as well. Coming to the mechanism of injury, causes usually fall on the outstretched hand. Momentum may be forcibly pronate the arm sometimes. Radial head usually dislocates forward. That is why most commonly it is the anterior one. Upper third of the ulna fractures and bows forward. Sometimes the causes, this force is causes hyperextension at the elbow, and which leads to this kind of a Monteggia fracture with anterior dislocation of the radial head. Coming to the clinical features, there will be definite history of trauma or a fall on the outstretched hand. There will be ulnar deformity, would be very much obvious. Marked swelling of the usually elbow joint would be present, and usually the dislocation of the anterior head may be masked due to swelling, but there will definitely pain and tenderness and restricted range of motion. Wrist and hand has to be examined for the signs of injury to the radial nerve. Why? Because the radial and ulnar nerve are actually passing through the elbow, and this can lead to damage to the radial and ulnar nerve as well. Now, what would we see on X-rays? On X-ray, there will be on a true anterior posterior view of the elbow. We may see the posterior lateral dislocation of the radial head, as I told you. There may be trans-Olecranon fractures, which may be associated with the radial head dislocation, or there may be associated fracture of the radius as well. Now, usually what we see is a backward and lateral bowing of the ulna. On the true lateral view of the elbow, and head of the radius may be dislocated forward, as you can appreciate it over this backward bowing, and the head is dislocated forward. This is a classical type 1 Monteggia fractures. Coming to the treatment of the Monteggia fractures, the important point is to restore the length of the ulna, and it has to be fully reduced, and it has to be stable. In adults, the treatment is always operation through the posterior approach and fixing the ulna with the plate and screws. A radial head has to be reduced, usually it reduces after the ulna is fixed. Stability must be tested, and if elbow is stable, then flexion, extension, rotation is started. But if it's unstable, then we keep it immobilized for 2 weeks, and then we start the range of motion early. The special feature in children is important because usually there may be associated with green stick or plastic deformation. Chronic subluxation of radial head may be present as well, or there may be incomplete ossification of radial head and capital epiphysis. Complete fracture is rare, but if it is usually there along with the Monteggia or Monteggia equivalent fracture, are best treated by open reduction and internal fixation in the case of children as well. Important point is if it's incomplete ulnar fractures, they're closely reduced. Force needed to straighten the ulna with the plastic deformation of almost 30 degrees is acceptable if 5 years are still remaining in 5 years of growth potential is still remaining. Flexion and supinating the elbow would test the stability of the fracture, and arm is then immobilized in a cast. With the elbow is kept in flexion and supination for 3 weeks. But it's only in the case of children. In adults, we have to fix it with the 4IF. Now coming to another important entity, that is the Galeazzi fracture dislocation of the radius. It is actually the distal 1/3 of the radius fracture along with the fracture dislocation and disruption of the distal radial joint as well. The mechanism of injury is such that it actually results in the fall on the outstretched hand with superimposed rotation of the force. Radius fractures in the lower third and dislocates, leading to inferior radial joint subluxates or dislocates as well. Now, important point is that we have to see whether this prominence or tenderness is present over on the ulna or not. There is painful movement, there is joint most of the time. There is always associated with instability most of the time in case of the distal radial joint. And we have to assess the integrity of distal radial joint by use of piano key sign. In this, if the ulna is subluxed more superiorly, the examiner presses it on the ulna as if it is a piano key, and it springs back to its original position as it is unstable. So if there is distal radial joint, instability is always there. Therefore, we have to not only fix the radius with which is fractured, we have to also worry about the distal radial joint stability as well. And that is always a test for ulnar nerve lesion as well, which may be associated with, because sometimes there is a pisiform is dislocated and the ulnar nerve may get damaged over here as well. Coming to the X-rays, X-rays usually show if you see this is definitely fracture of the radius as well as ulna is dislocated as well. On the AP view, you can appreciate the fracture of the radius as well. Distal radial joint is subluxed or dislocated. There is a transverse or short oblique fracture of the radius in the lower third of the radius most of the time with angulation or overlap. The treatment is to restore the length of the radius, which is the fractured bone. Close reduction is useful in children, but in adults you have to go for open reduction internal fixation. Reduction is first done by method, and then either most of the time it is done open reduction internal fixation, and compression plating and screws is done to the distal 1/3 of the radius. Then there are three possibilities. Then once we have fixed the radius with open reduction internal fixation, then what to do with the distal radial joint. Distal radial joint could be reduced and stable. If it's stable, then we can just continue with the armrest for a few days. Distal radial joint may be reduced, but it's unstable. Then forearm should be immobilized for at least in supination for a few weeks. Distal radial joint is irreducible. Now the point is, when we have to view it on X-rays, we have done the open reduction fixation, we applied the plate to the distal radius, and then you see on the fluoroscope whether whatever status of the distal radial joint. If it's still unstable and it's still dislocated and unstable, then the most commonly the entity involved is always the external ulnaris tendon. So when we've done the open reduction, we may have to open it up that side as well and make sure the external ulnaris tendon is not actually impinging on the ulna. And once we have done that, then we can go for TFCC repair as well, because sometimes open reduction of TFCC repair is required so that the distal radial joint can become stable. In this section, we have briefly covered the two important entities. One is the proximal ulnar fracture, which is called as the Monteggia fracture, along with the proximal radial ulnar subluxation. Now coming to the Galeazzi fracture, is the fracture of the distal 1/3 of the radius, along with the distal radial joint subluxation. Important point is, in both cases, whether it's whatever the subtype of Monteggia or whatever the situation with the Galeazzi fracture is in adults, it's always fixed. Open reduction internal fixation with stability of the proximal distal radial joint is the primary goal of the treatment. Thank you very much. Keep watching sqadia.com.